Sorry students, there was some internet issue over here. Now I was talking to you about the gross and microscopy of oncocytoma. Now this is, onto the left is the gross picture. What you can see is a large well circumscribed tumor of the kidney with a central scar, and it has a typical tan or mahogany brown color. Okay. The same oncocytoma on microscopy, they are composed of lobules of cells which have these, they are large cells with distinct cell borders and abundant eosinophilic cytoplasm with a round regular nucleus and some with prominent nucleoli. Okay. Now this is oncocytoma. One of these tumors again arise from the intercalated cells of the collecting ducts. Now we'll come to the tumor proper, which is the renal cell carcinoma, which is very, very important. There are different names by which this renal cell carcinoma has been addressed to as. Okay, it is called as adenocarcinoma of the kidney because of the arrangement of the cells in the pattern of tubules. They're called as in the pattern of adenoid pattern. They're called as adenocarcinoma of the kidney. They're called as hypernephroma because the adrenal glands which are situated next to the kidneys, with they're situated adjacent to the kidneys. No, so these tumors morphologically similar. They morphologically resemble these adrenal cortex cells. You know, they have those large cells with distinct cell borders and with clear cytoplasm. They're also called as Gravitt's tumor based on the person who first identified it. And lastly, they are also called as clear cell carcinoma because of the appearance of the cells. So these are all the different names of renal cell carcinoma. Now this is important for you because in your final exams in a question, there could be a question which says, please write in detail about the pathogenesis and pathology of hypernephroma, or maybe it can be given as Gravitt's tumor, or it can be given as in either of the names. Okay, in any of these names it can be addressed as. So you need to know all the different names of this renal cell carcinoma. Now, this comprises around 1 to 3% of the visceral cancers, and 85% of the renal cancers in adults are renal cell carcinoma. It's most commonly seen in 6 to 7 decades of life, and the male to female ratio slightly, it is more common in males. Okay, so the male to female ratio is 2 to 3 is to 1. Histogenesis, it is thought to arise from the tubular epithelium. Now, there are a number of risk factors which pose risk for the development of renal cell carcinoma. Among those which the list, there is a long list. Okay, among those, the first one is tobacco smokers. In tobacco smokers, the incidence of renal cell carcinoma doubles the incidence. Obesity, this is specific for women, and then there is hypertension, estrogen therapy, exposure to asbestos, heavy metals, and petroleum products, chronic renal failure, acquired cystic diseases, tuberous sclerosis, and mostly sporadic cases. Okay, mostly these are all the risk factors which are applied for sporadic cases. Now, 4% of these renal cell carcinomas are autosomal dominant and familial. Okay. Now, among these, this includes the von Hippel-Lindau syndrome, which comprises. You know, syndrome means there are a group of lesions which comprise which make up to that syndrome. Okay. Syndrome means, it means to say there are a group of diseases, or there are specific pathologies in different organs which make up to the syndrome. Now, von Hippel-Lindau syndrome comprises of hemangioblastomas of the cerebellum and retina, along with renal cysts and bilateral and often multiple renal cell carcinomas. Okay, and this is attributed to the VHL gene, which is a tumor suppressor gene. Hereditary clear cell carcinoma again is familial cancer, which is again related to this von Hippel-Lindau gene. Hereditary papillary carcinoma. Okay, so papillary is a different entity over here, which you'll see among the types, and this is attributed to this MET gene. MET gene papillary is, again, you have to remember that this is also seen in thyroid carcinomas. Okay, now classification of the renal cell carcinomas based on the morphology, based on the histomorphology, they are classified into 4 different types. The first one is clear cell carcinoma, which is the most common type, which comprises 70 to 80% of the tumors, and they have a clear to granular cytoplasm. They are non-papillary. Now, when I say papillary, it means to say it has to have the finger-like projections. Okay. Now, 95% of these cases are sporadic and 5% are familial, that is, which is related to this von Hippel-Lindau disease. 98% of these cases are will have the genetic abnormality of the loss of the short arm of chromosome. Okay, the one which is represented here as 3p means it is the loss, minus 3p is loss of short arm of chromosome 3, or there could be an unbalanced translocation between chromosomes 3 to 6 or 3 to 8 or 311. Okay, there could be non-deleted allele which brings about mutation or hypermethylation of this translocated gene, and VHL is a tumor suppressor gene. Okay, so in clear cell carcinoma, 98% of these include these deletions of chromosomes 3. Next is we have the papillary carcinoma, which comprises around 10 to 15% of renal cell carcinoma. As the name indicates, it indicates the papillary growth pattern, and it is seen in individuals who present with trisomy 7, 16 and 17 and loss of Y chromosome in males, and these are with sporadic cases. Familial forms include trisomy 7, where there is involvement of this MET gene, which involves the hepatocyte growth factor, which is responsible for growth, cell mobility, invasion and morphologic differentiation. Okay. Now, papillary carcinoma, there are both somatic and germline mutations. Papillary PRCC stands for papillary renal cell carcinoma, wherein chromosome 1 gene is involved, and there could be translocation between X and the 1 chromosome. There is a fusion gene with the end product of TFE, okay, which leads to the loss of chromosome 3 on X chromosome, and this leads to the formation of a fusion protein, which brings about the dysregulation of mitotic checkpoints. And papillary renal cell carcinoma can be multifocal in origin, so this is one important differentiating point for you to remember. The next one is chromophobe renal cell carcinoma, which comprises around 5% of the renal cell carcinomas, and these have prominent cell membranes. Okay, now prominent cell membrane with pale eosinophilic cytoplasm and halo around the nucleus, and these tumors also originate from the intercalated cells of the collecting ducts, and they have excellent prognosis. Okay, and the pathogenesis is multiple chromosome losses of hypodiploidy. The fourth one among the renal cell carcinoma is you have the collecting duct carcinoma or the carcinoma of ducts of Bellini, and they comprise around 1% or less than 1% of the tumors, and they have multiple chromosome losses and deletions. Histology wise, they comprise of nests of cells with prominent fibrotic stroma, and they are mostly medullary in location. Okay. As the normal histology goes by, collecting duct carcinoma is seen in the medullary region. So you're clear with the four types of renal cell carcinoma. The first one is clear cell carcinoma, which is the most important type. The second one is the papillary renal cell carcinoma, chromophobe renal cell carcinoma, and the third one is the collecting ducts of Bellini. Now this picture is trying to explain to you the cytogenetics and genetics of the clear versus papillary renal cell carcinoma. Okay. Now sporadic clear cell carcinomas have translocations between 3,6, 3,8 and 3,11, and also deletions on chromosome 3. There is loss of von Hippel-Lindau syndrome, inactivated mutated VHL or hypermethylation of VHL. The hereditary clear cell carcinomas can become multifocal, okay? Whereas the sporadic papillary carcinomas have trisomies 7, 16 and 17 with loss of Y chromosome, mutated activated MET gene, that is translocation between X and 1, which leads to the PRCC oncogenes. Hereditary papillary carcinomas, wherein there is involvement of this trisomy 7 with mutations and activations of MET, again it can be multifocal, okay? Now coming to the gross of this renal cell carcinoma. Grossly, renal cell carcinomas are represented as those tumors which are polar in origin. Okay, they are seen to arise in one of the poles of the kidneys, and they are large tumors which will distort the shape of the kidney, and the kidney will be drastically enlarged than to the compared to the normal size of its counterpart, and it will bring about distortion. Okay. And it will have a poculated surface to the kidney. This is the gross picture, wherein it is you cannot appreciate the normal morphology of the kidney. The bean-shaped structure of the kidney is lost here, and it is replaced by a large tumor. Okay, now here exactly we cannot say which pole it is, but it is seen to involve the upper pole of the kidney. Okay. Cross section of another specimen, wherein you are seeing a very nice. You can say that they are well circumscribed tumors, but they are not well encapsulated. Okay, so here you need to brush up about your differences between the benign and malignant tumors. It is clearly seen to involve the entire lower pole and the mid zone of the kidney. Okay, so this is the upper pole of the kidney, this is the lower pole of the kidney, and on cut section it is known to show that it has something called as a variegated appearance. Now variegated appearance is the tumor because of the expansile growth of the tumor. No, the tumor will have there will be areas of hemorrhage and necrosis within the tumor, which will give rise to these blackish spots with areas of hemorrhage, and these yellowish areas, whatever are showing, is all the areas of necrosis. Okay. Now tumor in the upper pole with hemorrhage and necrosis, it is the same. Another picture for you to describe the tumor very clearly in the upper pole of the kidney. This specimen is trying to explain to you the morphology of this tumor when it is fixed. Okay. Now, one important characteristic of this tumor is that now this arrow is pointing out to the hemorrhagic part of the tumor. Now, this entire this well circumscribed area is the tumor, and this is another tumor nodule which is trying to invade into the renal pelvis. Okay. Now, these tumors are known for metastasis, which I will be explaining it to you. Okay, now here again it is a tumor which has this is actually a multiple tumors which is showing multifocal in appearance. Okay, so there's one nodule here, there's one here, and it is the renal cell carcinomas are known, and they are known to invade the vessels. Okay, now this is another picture which is trying to explain to you the appearance of renal cell carcinoma in a multicystic disease. Okay, it can present as cystic, it can be entirely cystic. Now the normal brownish part what you're seeing here at the periphery is the normal kidney tissue, and this is the entire tumor which if you can closely observe is completely cystic with areas of hemorrhage. This is a fresh specimen. Okay. Now, on microscopy, these tumors are, as the name goes by, the clear cell tumors are, they are arranged in specific lobules, or you can call it as adenode patterns. When these tumors have, the tumor cells have clear, clear distinct cytoplasm with abundant clear amount of cytoplasm, and the nuclear grading. Okay, the nuclear grading is there's something called as Furman grading, which will try to explain to you as to the grade of the tumor. Okay, as the grade increases and the tumor becomes worse, the nuclear pleomorphism and mitosis and nucleoli can be seen more as the grade increases. That is called as Furman's nuclear grading for renal cell carcinoma. Okay. Now, what you can see here is for you to identify this tumor. This specimen and the slide both are there for your practical exams. So please pay attention here. What you'll be able to see is you have to search for the normal glomeruli to say whether it is to find out, to first confirm that it is a tumor arising from the kidneys. Okay. So you have residual compressed renal parenchyma and the tubules which are present adjacently, and they may not be a complete encapsulation, but there could be a circumscription for the tumor. Okay, they are arranged in glandular pattern or solid pattern, or can be in just in sheets with these uniform tumor cells having clear cytoplasm, some with granularity. This is the actual histopathological picture. Onto the right top here, you can see that there's a glomerulus, and these are the malignant cells. You cannot recapitulate the normal histology of the kidney over here because it is replaced by the tumor. Okay. Now, the four dominant subtypes of renal cell carcinoma, this is clear cell variant. This is papillary renal cell carcinoma, which is characterized by proper finger-like projections, that is papillae, which are lined by these atypical tubular cells, and this is chromophobic renal cell carcinoma, which is showing sheets of eosinophilic cells, and this is collecting duct carcinoma showing neoplastic papillary structures again here. Okay, now out of these, if you remember the clear cell carcinoma, it is more than enough. You should be knowing the other variants as well. Now, how does this renal cell carcinoma progress? Okay, clinically it can present as pain or a palpable mass in the retroperitoneal region, that is in the lumbar region, or in most cases it presents as hematuria. Okay, it presents as painless hematuria, which is kind of a more consistent finding with renal cell carcinoma. It can also present with fever, malaise, weakness, and weight loss, and in many cases it can just be an incidental radiological finding. It can also, in certain renal cell carcinoma is thought to, it is known for its representation as one of these paraneoplastic syndromes. Okay, so because it can present with polycythemia, hypercalcemia, hypertension, Cushing's syndrome, and feminization and masculinization because of the adjacent adrenal cortex which is present, and because of the paraneoplastic nature of these tumor cells to secrete the hormones with respect to these symptoms. Okay. Now, the 25% of the cases will show wide metastasis, and according to the organ involvement, the most important organ wherein metastasis is seen is in the lungs, that is around 50% of the cases. Next is bones, around 33%, and then it can also involve the regional lymph nodes, liver, adrenals, and brain. Prognosis, the 5-year survival is, if there is no metastasis, then the 5-year survival is around 70%. And if suppose the patient has metastasis, then the overall survival reduces to 45%. Now, this renal cell carcinoma is known and it is famous for its heterogeneous method of metastatic involvement. Okay, what happens is this renal cell carcinoma, though it is arising in one of the poles of the kidneys, it will try to evade and metastasize and enter into the renal vein. Okay, and from the renal vein directly it will enter into the inferior vena cava, and all the way from the inferior vena cava, it will reach up till the right atrium of the heart. Okay, so if there is renal vein metastasis, the prognosis reduces to almost 15 to 20%, and the treatment of renal cell carcinoma is nephrectomy. Partial nephrectomies can be done, but in cases of metastasis, only palliative therapy is given. The spread of renal cancer, it can spread through local infiltration through the renal capsule to involve the perinephric fat and the gyrata fascia. Venous involvement, that is heterogeneous route of involvement. It may grow directly along the venous channels to the renal vein or the vena cava. Lymph node metastasis, the lymphatic involvement, which can involve the local lymph nodes and also the inguinal group of lymph nodes. And distant metastasis is to lung, bone, brain, liver and adrenal glands. Now, depending on the involvement of the tumor and confinement of the tumor to the kidney, there are 4 different stages. Okay, stage 1 is when the tumor is around less than 7 centimeters in diameter. It is confined to either of the poles of the kidney, and it is well within the capsule. Stage 2 is tumor invasion into the perinephric fat, which is confined to the gyrata fascia, and it is larger than 7 centimeters. Stage 3 is when the tumor has involved the gyrata fascia and the outer capsule of the kidney, and there is an entry of this, there is heterogeneous spread of this tumor to the renal vein, is stage 3. Stage 4 is when there is distant metastasis to other organs. It is stage 4. Okay. Now, this is about renal cell carcinoma. Next, we're going to talk about Wilms tumor, which is also called as nephroblastoma. Okay, Wilms tumor is the most common renal tumor in children. It occurs as many as 10 cases per million children, and is most commonly seen under 15 years of age. The common age group of presentation is 2 to 5 years, and 5 to 10% of these cases can be bilateral. Okay, it can either be synchronous or metachronous. Now, synchronous is the appearance of the tumor in both the kidneys simultaneously, whereas metachronous is the appearance of tumor in one kidney first and then the appearance at a later date into the other kidney is called as metachronous. So synchronous and metachronous presentation can be seen with Wilms tumor. Okay. Now, pathogenesis and genetics. Wilms tumor is very, very important, and because it is one of the most important pediatric renal neoplasms. It gives an insight to a number of relations between the embryogenesis and the development of tumors, or the dysgenesis and development of tumors. Okay. Now, 10% of these tumors are associated with congenital malformations, of which the first one which is involved is the Vagar syndrome. Okay, which is confined to this, which is related to this WT1 gene, that is nothing but the Wilms tumor gene. Vagar syndrome is a syndrome which is comprised of aniridia. Vagar is, you need to split the word and try to remember the terms. W for Wilms tumor, A for aniridia, G for genital anomalies, and R for retardation, that is mental retardation. 33% of these individuals also, present with Wilms tumor, and WT1 is located on the short arm of chromosome 11 at locus 1 and band 3. So it is 11p13, which is the WT1 locus, and PAC6 is most consistent with aniridia. This is one syndrome, that is the Vagar syndrome, and the second one is the Danish-Dash syndrome. Danish-Dash syndrome again is a syndrome which is comprised of gonadal dysgenesis, that is male pseudohermaphroditism, nephropathy, that is renal failure, and germinal anomalies of WT1 gene again, and along with gonadoblastoma, which is a germ cell tumor, or which is an immature tumor arising from the gonads. Okay, WT1 is an important gene which is responsible for both renal and gonadal development. If you study embryogenesis, then you will know that WT1 is the development and the embryological maturation of the renal system and the reproductive system go hand by hand. The next important one is the Beckwith-Wiedemann syndrome, which comprises of organomegaly, macroglossia, hemihypertrophy, omphalocele, adrenal cytomegaly, and it is related to the WT2 locus, that is the WT2 gene, which is on chromosome 11, that is short term of chromosome 11, 11p15.5. And this you would have studied in detail when genetics was taught to you, wherein genomic imprinting comes to play, okay, wherein there is this inactivation. The maternal allele will be inactivated and the paternal allele will be active, and there will be reduplication of this paternal allele. That is called as genomic imprinting. Please go back to your genetics chapter and please look back into this genomic imprinting. So Wilms tumor associated with three different syndromes. The first one is the Vagar syndrome, second one is Danish rash, and the third one is the Beckwith-Bidman syndrome. Now, before we actually go on to the morphology of Wilms syndrome, we'll see what are nephrogenic rests. Okay, these nephrogenic rests are nothing but the precursor lesions of Wilms tumor, and in 40% of these are seen in 40% of unilateral tumors. Okay. Now, grossly, Wilms tumor are seen as a fleshy mass. The children will present with an enlarged abdominal swelling, which may the swelling may traverse back to the other line of the abdomen. Okay, it may cross over to the central line of the abdomen, and they will present as a large large swelling in the abdominal region. Okay, grossly these are seen as well circumscribed lesions, which are more commonly like fleshy. Okay, there is not much of hemorrhage and necrosis, but there may be there, but it is mostly a fleshy tumor. And on microscopy, it tries to recapitulate the normal embryogenesis of the kidney. So it contains the triphasic cells of the blastomer, the tubular and the mesenchymal components. So these Wilms tumor falls into the category of the small round blue cell tumors. Now onto the right side, what you're seeing is these abortive tubules. Okay, the normal embryogenesis where it is trying to recapitulate the normal glomerulus and the tubules over here, and this is the blastomal component. Blastomal is these cells are all they have very scant cytoplasm. They are arranged in diffuse lobules and in sheets, and they have very scant cytoplasm and dark hyperchromatic nucleus. Okay, which means to say that they're actively dividing. And in between is this mesenchymal component, which can be the fibrous or the mesenchymal tissue. Okay, this is the high-power picture of the same, wherein it is trying to explain to you about the blastomal component, where these cells are arranged in the form of minute tubules. And if you can notice, these cells have scanty to moderate amount of cytoplasm with dark hyperchromatic nucleus. Okay. Now, clinically, these tumors. Clinically, these tumors are common in the age group of 2 to 5 years. They present with palpable abdominal mass, and they present with hematuria, pain, intestinal obstruction, or hypertension, or in many cases they present as pulmonary metastasis. You know, these tumors would have already metastatized at the time of diagnosis. Prognosis is very good with nephrectomy and chemotherapy, and the 2-year survival rate is more than 90%, and they are prone for second primary tumors, and that also the prognosis is very good, and there's a very small percentage of tumors which can show anaplastic changes, and only those the prognosis is comparatively bad. Okay, next we'll go to the ureter, urethra, and urinary bladder. The renal pelvis, ureters, bladder, and the urethra are lined by a specialized multi-layer transitional epithelium called as urothelium. Okay, you've studied the histology of urothelium very well in your first year chapters. So this urothelium is around 2 to 3 cells thick in the pelvis, and around 3 to 5 cells thick in the ureters, and around 3 to 7 cells thick in the urinary bladder. The surface layer of this urinary epithelium, that is the transitional epithelium, has something called as umbrella cells, which wherein there is synthesis of this specific protein called as uroplakins. Okay. Now the lamina propria is comprising of this muscularis mucosae, which are irregular muscle walls within the bladder, and the proper muscularis propria is called as the detrusor muscle, which comprise of the bladder wall. Okay. Now the differentiation between the muscularis mucosae and the muscularis propria is very, very important when we're dealing with bladder tumors. Clear? Now this is the histology of the normal bladder epithelium. This is the transitional epithelium, which is called as the urothelium. This is lamina propria. This is the muscularis mucosae, and this is the muscularis propria. Okay. Now this is a special stain just trying to describe the urothelial cells. This is an and here you can see that the flat epithelium of this urothelium. This is in the resting stage. Okay. The 7-layer thick can be in the resting stage, and this 7-layer thick, when the bladder is distended, it can reduce to almost 1 cell thickness. The same picture again trying to explain the urothelium with the lamina propria, and this is the muscularis propria, which is the detrusor muscle. Now, congenital anomalies of the ureter can be double and bifid. Now, in any organ for that matter, we start off with the congenital anomalies, then we go to infection, then we go to inflammations, and then infections and any specific form of lesions present, and then we'll think about the tumors. Okay. Now, congenital anomalies of the ureters, you have double and bifid ureters, uretero-pelvic junction anomalies, and the non-neoplastic conditions include vesical diverticular, cystitis, and metaplasia of the bladder. Neoplastic conditions include urothelial papilloma of the bladder and urothelial carcinoma. The other variants are squamous cell carcinoma and adenocarcinoma. Okay, double and bifid ureters are anomalous development of a large kidney having a partially bifid pelvis terminating in separate ureters. Most are unilateral and they have no clinical significance because they will ultimately end up at the uretero-pelvic junction, and they don't cause much anomaly. Okay. Now, it's a uropelvic junction obstruction is a congenital disorder which results in hydronephrosis, which you have seen in detail when we have spoken about hydronephrosis. Usually manifests in infancy or childhood. It is more common in boys, and it is the most frequent cause of hydronephrosis in children and infants. Okay. Now, grossly, the renal pelvis is markedly dilated, but the ureter is not. Okay. So, indicating that the point of obstruction is at the uretero-pelvic junction. Now, there are two different types of mechanisms. Here, you can see that the entire ureter is normal and there is junction only at the uretero-pelvic region. The obstruction is the uretero-pelvic region, and hence dilatation of the pelvis. Now, here you have seen the what happens. No, the backflow of the urine will be taken back, and then the renal cortices and the glomeruli all will be affected, and hence it leads to dilatation and enlargement of the kidney. The second variety is wherein there is obstruction at the entry of the ureter to the bladder, wherein the entire ureter is also dilated, and this can be called as megaureter or megaloureter. Okay. Diverticular, hydroureter, and megaloureter can be present. Ureteritis is a complication of urinary tract infections. Malignant tumors arising in the ureter are similar to the transitional cell carcinoma, what you see in urinary bladder in the next coming slides. Okay, now a brief note about retroperitoneal fibrosis, which is a very uncommon cause of ureteral narrowing or obstruction. Okay, this is characterized by a proliferative inflammatory process encasing the retroperitoneal structures and causing hydronephrosis. Okay, and this occurs in middle to old age, and retroperitoneal fibrosis is very, very important to rule out the other causes of hydronephrosis. 70% of these cases are primary or idiopathic, which is called as hormone disease, and the rest of the cases are related to the elevations of serum IgG4. The serum IgG4, a group of disorders which are related with the fibroinflammatory lesions which are rich in IgG4 secreting plasma cells. Okay. Now, others are associated with drug exposures like ergot derivatives and adrenergic blockers, and rarely malignant diseases such as lymphomas and urinary tract carcinomas can also produce retroperitoneal fibrosis.